Great. Yeah. Well, thank you everyone for joining this morning. I'm very thrilled to be able to present some of this work and to talk a little bit about an area of research that I really care about and that I've worked a lot on for the last few years, and hopefully we can have some helpful discussion at the end. I'd be very interested in some thoughts after I present some of this work that I've done and been involved in with our team here at Dartmouth in the United States, and some of the potential next steps for this type of work, and how technology may play a role in supporting interventions to address early mortality in this patient group. So I'm going to start with presenting a little bit of background about this work, and then about why it's important, and then also a little bit about some of the different studies. I'll walk through a selection of preliminary studies, and then think about some of the next steps for this work. By way of introduction, I am currently a research associate at the Center for Technology and Behavioral Health at Dartmouth College. The work I'm involved in is focused largely on efforts to use digital technology to support mental health care, both in the United States and other high income settings, as well as many lower income countries, and currently very heavily involved in a project in Latin America focused in Colombia on with Javeriana University in Bogota, focused on scaling up mental health care in primary care settings in the region. So have some work in a variety of different settings, and then also through community mental health settings here in the United States. So I'm located in Boston at the moment, but split my time between Boston and New Hampshire, where Dartmouth is located. They're very close by. So I'll get started. First thing, I'm going to focus a lot on some numbers and facts from the United States, and the main reason for that is that's where a lot of my work has been focused. So I think just to start off, why focus on this patient population, this group of individuals with serious mental illness, and who exactly are they? So when you think of the population, about 1 in 17 people in the United States, and this is pretty consistent globally, live with a serious mental illness. And a serious mental illness includes schizophrenia. So we're looking at, in the United States, there's about 2.6 million people with schizophrenia. Bipolar disorder affects roughly 6 million people. And then major depressive disorder, and that affects a larger percentage. But in any case, this is typically consistent across many different countries, these sort of these rates of serious mental illness within the population. And there's some reasons why serious mental illness is really important to consider. When someone has a mental illness like this, it has a pretty severe impact on how they function and on their health and well-being. So this individual who has a serious mental illness is at increased risk of facing discrimination, and we know that's from in the form of stigma. We also know that these individuals face greater disadvantage and poverty. So this is very consistent across any setting in the world, but especially in the work that I've been involved in here in the United States. Definitely high rates of homelessness in this population, very high rates of poverty, high rates of substance use. So co-occurring substance use disorders are very common in people who have a serious mental illness. And then, as I mentioned, homelessness. And then also, one thing that's quite striking is that the quality of health care that these individuals receive is generally very poor. First of all, very few of them receive any treatment whatsoever. And then among those who do receive treatment, a very small portion of it is considered adequate. So this gap, just often described as the treatment gap, between those who have a mental illness and those who receive adequate care is quite sizable. And this is, again, something that as you move from higher income settings to lower income settings, the gap is even wider. So we see that even here in the United States, few fewer than half of people with a serious mental disorder receive any care for their condition. But there's more that we focus on, and what I particularly focus on is the fact that individuals who have a serious mental illness also have a significantly shortened life expectancy. So data in the United States shows it's quite a wide variability in shortened life expectancy. It can range anywhere from 8 to 32 years shorter. In general, the gap in life expectancy is enormous. So people who have a serious mental illness die considerably earlier than anybody else in the population. And this is largely due to treatable chronic health conditions. And this is a big part is attributable to poor lifestyle behaviors. So we can think of things like obesity rates are really high in this population group. Rates of cigarette smoking are often considerably higher. And then, as I mentioned earlier, the quality of health care that these individuals receive is often much lower quality. So they're not getting treatment for conditions early on. And often these things, chronic conditions, become actually quite a problem earlier in life for these individuals than compared to people in the general population. So it is not often that's a misconception that suicide is a major driver. And while suicide is a major contributor to early mortality, it is not the leading cause. It really is due to preventable chronic health conditions. And what I'm going to focus on in the presentation today is really thinking about obesity and some of the factors that contribute to these high rates of obesity and some of the work we've done at our research group to try to address this. So why is obesity such a significant problem in people who live with a serious mental illness? And there's a few reasons for this. I think for one, the medications are definitely a significant contributor. We know from considerable evidence that medications do contribute to metabolic syndrome and increase in weight gain. We also know that living in poor neighborhoods with inadequate access to resources for physical activity or living in unsafe neighborhoods is also a contributor to poor physical health and higher obesity rates. We also know living in food deserts is a major problem. So access to healthy and affordable foods is a very serious problem in many communities in the United States, and especially in lower income settings where it's really not possible to access or it becomes more difficult and costly to access healthy foods. But there's other factors too. I think it's important to recognize that there are a number of barriers to living a healthy lifestyle. Again, these are in the form of things related to stigma, discrimination because of having a mental illness, and then also the symptoms of having the mental illness itself. It can be very difficult to have the motivation to address physical health issues when you have debilitating mental health symptoms or when you're facing all this uncertainty and chaos in your life. And that's the last thing I want to highlight is really this lack of control that many individuals often have, especially when they are faced with a serious mental illness and the symptoms they have to manage. And that's compounded by the fact that they're living in, say, poor housing, unsafe neighborhood, and then have a number of other challenges to overcome in order to exercise or to eat right or to focus on a healthy lifestyle. So that's really what I'm going to focus on today is how can we overcome these challenges to try to support programming to address this early mortality disparity. So again, it's absolutely critical to address this disparity, and this gap in life expectancy that we observe in people with serious mental illness is consistent worldwide. So it's not something that's only focused in certain countries or certain parts of the world. It really is something that's consistent in most epidemiological data that has been collected. So the two main objectives that I'm going to focus on in this presentation and in the work that I'm going to talk about are really thinking of efforts that have been successful for promoting, for health promotion in people with serious mental illness, and then also thinking about new ways that we can use technology to try to support and reinforce and extend the reach of these types of efforts. So I've separated this into really three sort of broad themes. I like to focus first on the conventional health promotion and thinking about some of the existing methods And the reason that this is so important is that we want to first understand if interventions and programs can actually be beneficial in this population group. And part of why that's so important, we've now established that these programs do work, but initially there was, I think, some skepticism that it's not possible to help individuals with serious mental illness lose weight and live a healthy lifestyle unless you take care of their medications, or it really isn't possible to address anything unless you switch the medications. So there's evidence, and very strong evidence, showing that even with these medications that have bad side effects, and with all the other things going on in their lives, you can successfully contribute to weight loss. And I'm going to just highlight a few different programs that have been very successful in settings, community settings in the United States. So we've seen that there's the InShape program. This one here from Gail Dalmut's group is that's out of Johns Hopkins. They've had a very successful program for contributing to clinically significant weight loss. There's the STRIDE program. They're based out of Kaiser Permanente on the west coast of the United States, and they have again have had very important success in treating obesity and cardiovascular risk in people with serious mental illness. And then there's also the InShape program, and that's a program that I've been involved in. My primary mentor on my dissertation was the lead investigator on these studies, and again, it's shown success in community mental health settings in several different parts of the United States. So I'm going to just highlight a couple findings from a systematic review and meta-analysis that we conducted in our group. And part of why this is important, just to sort of set the stage, is really just to highlight that these lifestyle interventions can be successful. So I'm going to just show you that we identified 17 studies, and they were primarily from the United States. There were some from Europe as well, and then some from Asia. And we looked at studies that had short duration interventions and then longer duration interventions. And the reason that that is really important to consider is oftentimes in this disparity population group, it's really important to have more intensity and longer duration to really support these health behaviors over time. So that's where we thought that if it's a longer duration intervention, it most certainly it would hold the potential to contribute to better outcomes, simply because the shorter duration is just not enough time for individuals. It's not enough time to provide adequate support for individuals who have many other competing demands and challenges in their lives. So these studies recruited about close to 2,000 participants, and they focused primarily on healthy eating and physical activity. And they were mostly conducted through community or outpatient mental health settings. So I'm going to go through these relatively quickly, just because I want to show just some of the findings, just to really emphasize that lifestyle interventions can be effective and successful. So in this first one here, this is looking at the shorter duration studies, and we found that yes, there in fact was a significant difference. The standardized mean difference you can see here was significant, and then that was also the case for the 12-month or longer interventions. But what I also want to draw your attention to is the fact that the longer duration interventions had much less variability or much less heterogeneity in their designs. And what that really shows us, based on this I-squared test, is that these studies were more consistent, and potentially that the results can be replicated more easily across different settings. So this is highlighting that the findings in the larger studies are more robust and are consistent, I think, with literature also from the general population for achieving weight loss using lifestyle interventions. The last thing I want to highlight with these is that we looked at ability for these programs to achieve clinically significant weight loss. And the reason that's really important is that we know that without achieving clinically significant weight loss, we really don't know if the program is contributing to a reduction in cardiovascular risk. And we know that that's really most important towards addressing this early mortality gap that exists. So in the studies that were longer duration, we found that the odds of achieving clinically significant reduction in cardiovascular risk, defined as clinically significant weight loss, there's actually a 1.62 odds ratio, which again is highlighting that these are fairly robust findings and show that It's also consistent across different settings, across different intervention designs, but similar study designs, which is, so the interventions are designed differently. They may use different methods, but the studies were fairly consistent. They were randomized controlled trials and then across different settings. And again, there was low heterogeneity, showing that these are robust and consistent findings. So the reason these are really important, just to sort of set the stage, is that this confirms, I think, that there is strong evidence that exists that we can achieve clinically significant reduction in cardiovascular risk in this very high risk population group of people with serious mental illness. So what we want to try to figure out now is we need to think beyond these conventional approaches. And the big reason for that is a very small number of people actually have access to these traditional programs. There simply aren't mechanisms to pay for these types of programs and to make them widely available. And there's many individuals who just simply cannot access them. And this is for a number of reasons. So we need to think of new methods, and then also ways to improve the impact of these programs. So this is really where it draws from some of my interests, is how can we think about technology as a way to potentially support health behavior change and to support these lifestyle interventions in people with serious mental illness. So some of this work, where I initially began, was trying to think about some of the theory that might support how technology can really be integrated within an intervention and provide the necessary support at the right time. So before I get into how technology can work and then some of the findings from our preliminary work, I want to just make it clear that digital technology for health promotion, digital technology is something that we have lots of evidence that people with serious mental illness are using these devices. They do have access to smartphones. This is something that has been increasing dramatically in this population group just in the last few years. You can see on the small graph, this has been catching up very steadily to the general population. In a survey that we conducted through a community mental health setting, again, this is a fairly underserved population group, we found that cell phone ownership and internet use and text messaging were all very comparable between the national averages and the sample that we surveyed. Though we did observe that smartphone ownership was slightly lower in people with serious mental illness, and that had a big reason for that is just the cost of owning the phones. But then that is also changing very quickly. So there are still many people without access, but this is something that is changing, and increasingly people will have access. The other thing to think about is, so how can the technology support the path to health behavior change? And that's something that I think we have to really think about carefully. So I like this picture because it shows you, we think health behavior is like a direct line, changing a health behavior is very straightforward, but in actual fact, it's very complicated. And it looks something more like this crooked line. I mean, you have ups and downs. Trying to get someone to change a health behavior to make improvements in their lifestyle is never straightforward, and it often requires a lot of effort and work. And what I think is really important is that technology can help guide people at these different points. So there could be time points that are more challenging than others, and a mobile application or a mobile device could deliver the right support at the right time to help people move towards their health behavior change goal. So then this is where I think theory could play a role. And the reason theory is important is it's a way to help guide the research that we're doing. It's a way to help think about how we're using technology as part of our studies. And I think it helps us develop very rigorous hypotheses before we try to integrate technology within interventions and then run trials to test it. So this next study I'll just highlight again. It's a bit more of a review, but it's really thinking about how technology could, how theories of human behavior and how the different constructs of these theories could be used to help inform digital health interventions for people with mental illness. And part of what we did in this work was first looking at what theories are very prominent and have been used a lot in the health behavior change literature. But then we also considered how new theories, there's emerging theories, how these could add additional insights for helping us develop interventions that are both effective and can support health behavior change. So I just will highlight the key theories that we looked at. And on the one side, there's very traditional theories. We have the health belief model, theory of planned behavior, trans-theoretical model, social cognitive theory. These have been around for a long time. On the other side, we have these emerging theories. And the reason these are important to think about is digital technology has really changed the way we can support health behavior change. We can now reach people at different times of the day. We can reach people using different methods. So many of the concepts or the core constructs are very similar to the existing theories, but their delivery mechanisms different. So the theories have been adapted to account for these changing dynamics of how we use technology. And we can think of there's just-in-time adaptive interventions, so interventions that could potentially change over time as someone is working towards health behavior change. So we came up with sort of a conceptual overview of how theory could help support a technology intervention. And there's a number of different ways. Thinking of how an individual's characteristics, so the actual demographic characteristics or personal preferences, can actually shape how the intervention is designed. And I think that's something that's also very novel with technology, is we can actually account for what a participant wants, what they like, what they don't like. We can actually take those preferences and incorporate them into the design of the actual intervention. And then not only that, as the intervention is being delivered, we can think of ways to learn over time and rapidly how the intervention is working. And I think this is also really important because this can allow us to make modifications to an intervention in real time. And then we can also understand how this impacts the outcomes. And then because most health behaviors, really, it's not a one-time change, it's ongoing. It requires ongoing management of mental health symptoms or ongoing lifestyle behavior change, ongoing sort of work on these health behaviors. This is something that we have to also factor in long term. So this is something that will go on over time. And how can we take the inputs and what we learn over time to reinforce use of the digital technology intervention? So now I'll try to show how we're using this in some actual real-world studies. And I think what is really important before going too far into the studies is to think about feasibility. So we've got the theories to help us understand potentially how technology could help, but we also need to think about, is it actually feasible to use technology in these settings and with this population group? And is it acceptable? Is this something that participants actually want and are interested in using? Are they interested in having a digital device support a health behavior change over time? And then we also want to know more about how participants actually use devices, because that also can help us understand how these interventions can work. So this is, again, and then thinking, how do participants actually want the technology to help them? And then also, how can these technologies actually be integrated within community settings? Because that's really where the majority of people with serious mental illness, when they do have access to care, they do access it through community settings. So we want to think about how to integrate these digital tools within these types of settings. So I'm showing just some of our really early preliminary work thinking about just really feasibility. And we had remarkable feasibility. We started with just wearable devices. So we used a few different commercially available wearable devices. I've been doing this for a while because I think when I started, one of the devices that I tested was actually the Nike Fuel Band, which no longer exists. So our research group, we used Fitbits for quite a while, and now are currently working in collaboration with Fitbit on other projects. But I think just to highlight, we had very promising findings with using Fitbits in this population group. And I think this is important to recognize because participants use these devices, and they use them a lot. They use them for most of the days they were in the study. So this next study that I'm going to show the results from was really taking this a step further and trying to understand if the actual use of the devices over a period of time, so over 6 months, whether the daily average step count would be associated with weight loss and improved fitness. And I think we wanted to find this out because we're trying to understand if actually using these devices and having them as a tool to help participants self-monitor and keep track of their health behaviors over time, whether it is also something that contributes to a meaningful clinical outcome. So we conducted this this was a study through a community mental health center. I recruited a sample of 34 participants through the center. They were enrolled for 6 months. They all received Fitbits as part of the study. They got those for participating. And then they were sent text messages as reminders to use them. So we did find ways to encourage participants to use the Fitbits. And we found that they really did use them a lot. So participants wore them really for about 86% of the days that they were enrolled in the study. So the study was rolling enrollment, and this is to account for the differing lengths of time that participants were actually in the study. Then I wanted to look using simple linear regression models to just determine what the association between this average daily step count over the 6-month study duration and then the changes in participants' weight and fitness. So what we found is actually that when participants got, on average, a higher number of steps, daily steps, they had they achieved significant weight loss. And this was really, really reassuring for us because this really showed that having something like a simple device, a wearable device, and using something as simple as text messages to remind participants to wear it, and to encourage them to wear it, it showed that by actually getting more steps, they did in fact lose more weight. And then, interestingly, our fitness was in the right direction, though our relationship between step count and change in fitness, and we measured fitness using a 6-minute walk test. This association was not significant, though the direction was consistent with our hypothesis. And this may be partly because it was a small, underpowered study, and then it also is likely partly due to the fact that many participants did not actually show, they lost a lot more weight than improvement in fitness. So as a key takeaway from this small study, this small pilot study, we found that wearable devices may actually be an effective tool for supporting behavioral weight loss in a community mental health setting. We also found that what I think is an important message from this is that this is a very simple way to encourage health behavior change. It's something very tangible, it's easy to understand, it's a matter of just collecting more steps, and just that act alone we found may contribute to greater weight loss. And I think that's really important because in many of the existing programs that are lifestyle programs that are delivered in many settings, we adhere to these national standards for physical activity. So in the United States, the recommendations are to achieve a weekly average of 150 minutes of moderate to vigorous activity. And those are important guidelines, and they're evidence-based and they're well established. But some of the challenges with those guidelines are that they're difficult to understand. And for a low health literacy population or a population that doesn't have much prior exposure to these types of guidelines, that can be actually kind of hard to understand. And it can be difficult to figure out, well, did I get 30 minutes today? Did I get 20 minutes? Does walking count? So there's many ways that those guidelines can actually be a little misleading. Whereas just telling participants to get more steps, one thing I learned from talking with participants afterwards, through qualitative interviews, is that this was a very simple way, something very simple for them to do that they could focus on no matter what. They could always say, you know what, I'm just going to get some more steps. And that's a very simple method to try to promote physical activity and potentially contribute to weight loss. So I'm going to move on to the last sort of theme area that I'm going to talk about today, is just this thinking about some of the next steps for technology, and an area I'm really interested in, and that's how social media may be an effective platform for promoting for health promotion. So I think some of the reasons why, I think we may be aware that there's a lot of social media users worldwide. I think we're looking at well over 2.5 billion. I think it might be 2.8 billion social media users, and that's worldwide. So it's very, very high reach. And it is something that many people are using. And as I showed earlier in the survey that we conducted, use of Facebook and use of Twitter were very comparable in the community samples of people with serious mental illness that we worked with. So one thing that I was very interested in is, well, how could we use something like Facebook to actually support a lifestyle intervention? So this exploratory study involved use of a Facebook group over a 6-month duration. And I was really interested in trying to find out whether use of this Facebook group, so when I mean use, that's like whether participants engaged in it, and I'll talk about what that means in a second, whether that actually contributes to clinically significant weight loss and fitness. And then the other thing I was wanting to find out is what types of content in the Facebook group could generate these different responses from participants. And the reason that's really important is this is a way to help us understand how to design interventions and how to integrate theory into supporting these interventions to support health behavior change. So I'll just walk through the methods relatively quickly. We had a sample of 25 participants. They all, again, had serious mental illness, primarily major depression, as well as some bipolar disorder and schizophrenia. The Facebook group was active for a 10-month duration, though participants' outcome data was collected at baseline and then at 6 months. And the reason it was active, the group was, again, it was a rolling enrollment, and the group, the Facebook group, was longer because participants joined the study at different time points. Out of the 25 participants, we had 19 who agreed to join the Facebook group, and I think that's important to recognize that Facebook's not something for everyone. Some of the reasons for not joining, some participants really didn't feel comfortable using Facebook. That was one thing. Others, it was just not something that they had ever used and had no interest in learning how. So a couple different reasons, but definitely the privacy part did come up as a reason not to join Facebook. So these are the number of interactions that we observed, and I defined interactions as consisting of posts, so actively posting content, providing comments, or liking content. So really actually being active. And we had peer facilitators, and I think that's important to recognize, is that these facilitators contributed a lot of the posts, and they were really, when I say peer co-facilitators, they were 2 individuals with lived experience of having a serious mental illness who had also worked on engaging in health behavior change. So they were actually 2 prior participants from another study of ours. One of the other studies, they really were interested in supporting health behavior change and volunteered as peer co-facilitators for this Facebook group. And then the study staff, and there was lifestyle coaches as well. The staff and coaches contributed far fewer interactions, but were also part of the group. And I think it's important to recognize there were no hurtful or rude comments or content posted in the group at any time. This was a secret group, so it was by invitation only. And participants who joined the group were informed of the rules, so they really knew, they understood that this was not a place to talk about other things other than and how to live a healthy lifestyle and maybe some of the challenges or difficulties with living a healthy lifestyle. What we found, this was a very small sample, but when participants posted more in the group, it appeared to be associated with cardiovascular risk reduction, and that was defined as weight loss or improved fitness. So this test was not statistically significant, though it was clearly in the right direction. So participants who achieved cardiovascular risk reduction posted on average 19 or so posts, interactions within the group, versus those who did not posted around 4. So this suggests that maybe more interaction is contributing to or is associated with this improvement in clinical outcomes. And that's really important because that tells us that participants who interact in the group may also be engaging more in the program, and then may also be more, more interested in, or more engaged in actually some of the behavior change techniques necessary to help improve fitness and lose weight. We also, again, saw that weight loss was a near significant association. And again, this is adjusting for the unequal variance between groups, and it's also a very small sample size, just as a caution. The finding that I think is quite interesting from this is the content of the group. So I know there's a lot of text on this slide, But I just want to draw your attention to, we had different categories of content, and these are really broadly defined topics such as healthy eating, and that could really be any type of post about eating a healthier diet. But what really was the main driver of interactions was personal sharing. And the personal sharing piece really, that was when participants shared their own stories or their own challenges or successes with achieving health behavior change. So what that tells us is that there might be a peer-to-peer aspect of the Facebook group. So when participants can support each other and share their own experiences, they may in fact do better, or they may interact more in the group, and these interactions may be associated with greater weight loss. So these are just a couple sample posts. I can see these cut off a little bit, but the first one here is just showing a participant who lost a family member and experienced a number of challenges. And what happened is when this individual posted this into the group, it was met with overwhelming support and encouragement from other participants. And many people would post like, hope you're doing well, and it generated really positive feedback. Another participant was, you can see below here, was dealing with a number of challenges outside of the program, and again, shared this with the group. And this was again met with a lot of encouragement and support. Another thing that we observed with the Facebook group is that many participants, they did not know each other, they'd never met each other face to face, and got to know each other very well using the Facebook group and support each other online. So we found that this could be a effective platform for supporting peer-to-peer support just to encourage lifestyle behavior change. So I'm going to, just for sake of time, I only have a few more slides, but I want to just get into this idea of potentially online networks for supporting health behavior change. And this last study is building, it's really trying to understand, so what motivates someone to actually go online to seek support from their peers? And we know that in people with serious mental illness, a lot of them are active online and do actively seek support from others. And some early work that I did was looking at, I helped lead this project looking at posts on YouTube among people with serious mental illness, trying to understand the type of response that this generated. And it really was clear that this social media platform and other platforms too are really a way for individuals who live with a serious mental illness to find other people who have similar experiences and to learn from them or to share their own experiences. And this idea really, I think, is it's driven partly by the symptoms and uncertainty of living with a mental illness, potentially feeling isolated, and it's a way to reach out in a safe way, because you can do it with relative anonymity, so people don't know who you are, and oftentimes many people don't have a family network that they can reach out to because of the stigma related to their mental illness. So this is a way to overcome some of those challenges potentially. So I wanted to explore this further, and this was really using some surveys and then interviews with social media users who self-identified as having a serious mental illness. So this one here was really this last study was to learn about the characteristics of these individuals, and then also to try to get a better understanding of why they might use social media for their mental health, and whether this might be a useful platform for delivering interventions and lifestyle programs. So I reached out to a lot of people on Twitter. Twitter was the platform that I used for this study, partly out of familiarity and also because there's a really active community on Twitter. And I'll just highlight that I sent out 240 tweets and ended up with 135 completed surveys. But I had people from really all around the world. I think the limitation was mainly, it was driven by English language. So I did all my surveys and outreach using English. And the most common disorders were schizophrenia spectrum or bipolar disorder. And most participants expressed interest in receiving mental health programs through social media. So this was really, really highly validating. It really helped show that this might be a platform that we could use to support lifestyle behavior change. And I'll just highlight this. This was looking at age differences, just in case there was a difference in the younger age groups, which are usually harder to reach and also use social media a lot more than the older age groups. And again, we saw it was pretty consistent that promoting health and well-being was a major interest. Also coping with mental health symptoms, also a lot of interest for programs that might be delivered entirely through social media to help support these aspects of health and well-being. So this is kind of this walks you through where the work that I've presented, thinking of taking the conventional evidence, thinking of new ways that technology can support health promotion, and then thinking about how we can use social media and leverage that for health promotion. I don't want to use too much more time. I want to leave time for some questions, but I think also just want to highlight that there's potential for global impact and international work, and potentially reaching across a number of different countries. And I think this, again, is driven in large part by the increasing use in mobile phones and digital technology worldwide. And I want to just highlight findings from a review here. Again, this is the social media use worldwide is increasing rapidly. But this review here that we conducted was really looking at digital technology interventions from low-income and middle-income countries. And I think that this is an area that there's potential for exciting growth, because there may be ways to deliver interventions that span numerous countries that are not constrained by borders or different clinical settings, because I think we could leverage social media to really reach a number of people and to reach those who may be most vulnerable and don't have access to clinical services. So I think I'll wrap it up from there. Just want to highlight, I think, some of the key challenges for digital technology going forward. We definitely need larger scale trials with strong comparison conditions. I think costs is something that really has not been looked at very much. And then also the risks. I think that I don't want to underestimate that there certainly are risks, and there's been limited consideration of these risks. And I also think the equity part is important to recognize. There are still many individuals who do not have access in all parts of the world, and that can be due to a number of factors. So I think technology is an important tool, but it's not something that can really reach everyone. But I do think there's some very exciting future opportunities, and I think that's really thinking about how we can integrate technology into the daily lives of individuals living with serious mental illness, how we can really involve participants in developing these interventions and implementing them, and then thinking of global collaborations where interventions could really span numerous countries to try to learn from a larger patient group and a larger community, I would say, of online patients with serious mental illness. And then I think also it's this idea of no health without mental health. I think really supporting lifestyle behaviors, but also mental health at the same time, are critical for the success of these programs. So I will wrap up from here. That's all I have. Thank you very much, everyone, for your attention. I see we have a little bit of time. I ran a little bit over, but I'd be very interested if there's any questions or comments about this work or thoughts about the next steps. Especially interested in that. We didn't get cut off. Hello?
John, we have a question here.
Yeah. Oh, great.
In the chat. I'm going to read it to you, okay?
Oh, sure. Yeah, I can try to look at it too.
Yeah, it's here.
Oh, yeah. So I think the question, I'll try to summarize it, is thinking more about the risks of using these technologies and the ways of addressing this. And I think that's an excellent question. I know I did add the risk piece in there, but I didn't spend much time talking about it. And I think when we think of risks, It is really important to be thoughtful about that. At the same time, what I also know is that many people with mental illness are already very active on these online platforms. So they're already there, whether we're trying to deliver programs or interventions to support their mental health or lifestyle behaviors through health promotion programs. So I think understanding that this is already part of the daily lives of most people now is important, because if this is a place where people are already active, then it may also be an important way to try to engage them in interventions. But I do think there are really important risks. I think the privacy consideration is important. I think there are concerns with being able to react to crises online, being able to address really serious concerns that come up in a timely way. And I think we don't have the answers for that entirely. This is something that I'm really interested in learning more about. I'm currently working on a project trying to think more carefully about the risks. A lot of the work that I've done has been lower risk because it's been focused on lifestyle behaviors and less so on sort of clinical management. So I think this is something that we want to really make sure that we have participants really involved in thinking about the risks, and then also having researchers and clinicians especially really thinking carefully about this moving forward. But yeah, I know that may not completely answer your question, but except it's an area that I'm really thinking a lot about, and I think we have to really draw from different disciplines to try to fully address these concerns going forward. Yeah, so I would be happy to share any the slides from this. I can send like a PDF of the slides or something, because I think there's some animations that might not work, or I can send papers. I don't know, Kelvin, if there may be interest in that.
Sure.
And anyone is free to certainly reach out to me. Okay. Yeah, thanks so much for all of your feedback. I'm pleased that so many people joined the webinar. Oh, I like this comment. Yeah, Julietta's comment about using Facebook this way in Latin America in Portuguese. Wouldn't this be a nice challenge? I think that would be very exciting, actually. And as part of the work that I'm involved in Colombia, we actually conducted a survey through primary care sites in Bogota, and then also in some of the surrounding areas, more rural or semi-rural areas. And we found that social media use was very high. And I also know from some of the statistics, I think Brazil is one of the highest users of social media in the world. So I think there's definitely potential. I think it may be the third most Twitter users, I think, after the United States and Mexico.
Hey, John, let's begin the question. It's mine.
Oh,
I'd like
great.
to I'd like to know more about the ethical questions about these studies. I mean, you use Twitter so effectively to reach these people. How could you get a consent from them or something like that? Did you can you share us, enlighten us about this?
Yeah, so when so how did I consent them? I had an information sheet because I was not, so this started off as exploratory work, and I reached out to participants, to individuals on Twitter, directly reaching out to them, and the procedures that I used were approved by our institutional review board, the ethical review board, but I purposely did not collect any personal information from participants. So I left the questions. There was a survey. It was anonymous, the survey, and it did not include any sort of personally identifying information, and I did that purposefully. But then I also interviewed some participants, and the interviews were generally by phone or were by Skype, depending. And again, in those interviews, I walked participants through like an information sheet. I described to them the purpose of the interview, what I was trying to accomplish. I'd be happy to share those materials. But again, I made sure that participants understood that what I was doing, I was very transparent about my role as a researcher. And actually, when I first started, I used Facebook to try to recruit, and then I used Twitter. And the ethical review board here at Dartmouth said that I had to use my personal accounts. And at first I thought, oh, I don't know if I feel comfortable doing that. But they said I had to use my full name and my personal account, and I had to show who I was in order to be fully transparent that I'm a researcher at Dartmouth, and this is the work I do, and you can find me. So I think that actually worked very well because participants then saw that they could see who I am, they could see I have a profile. So I think it looked very trustworthy. It wasn't like it was a bot or some kind of spam. And I think that actually worked very well. But for me at first, as a researcher, I had to kind of break a barrier down and sort of just go out there and put all my information online, which I think in the end worked well. But at first I was like, oh boy, I don't know if that's something I can do. But it ended up working very well. So I think that may be one of the things that helped with the getting consent and being very transparent about the purposes of the research and who I am and what institution I'm from. So I think transparency was really key in that work.
Wow, that was really nice and different using your personal profile.
Yeah. Well, it was an interesting experience at first, but I realized they're really interesting. They were really interesting and genuine and just wonderful people that I met, and they were really from all around the world. I recruited people from parts of Asia. It was really anywhere where they speak English, actually. So, but they were, yeah, just really wonderful people, and I think that was partly because they could tell who I was.
It was really nice. John, I'd like to thank you very much for participating in our study group, and I think we can call it a stop by now. Thank you very much. Really, it was really enlightening. Your research is amazing. Thank you.
Oh, thanks so much, Kelvin. And again, I will share the slides that I have, and again, if there's any questions or any interest in any of these, any of the papers or resources we used, I'd be happy to share them. So, and definitely always open to new collaborations. I think there's a lot of exciting potential in this area. So thank you so much for joining today.